Today's conversation sits at the intersection of science, rehabilitation, and the future of neurological care. Our guest is Haseel Bhatt.
My first piece of advice is that things can improve with Parkinson's in the face of a neurodegenerative condition. No two people living with Parkinson's are the same.
It's on you to actually, create your team and try to you take the ownership on your life.
Exercise is no longer an adjunct therapy. It's a core component of managing their Parkinson's. They call it the fingerprint assessment for Parkinson's, a rehab program that you will actually stick to. We look at motor symptoms and non-motor symptoms, different domains of movement like aerobic capacity, strength. We look at things like motivation because we know apathy can be really affected in Parkinson's.
Helping people reclaiming ownership over their nervous system.
Give people the tools and access to help themselves live well with Parkinson's.
Welcome back to the Parkinson Performance Center podcast. Today's conversation sits at the intersection of science, rehabilitation, and the future of neurological care. Our guest is Haseel Bhatt, neurological physiotherapist, researcher, educator, and founder of Neurology Rehab, adjunct lecturer at the University of Toronto, and someone who has built his career around the question that matters deeply also to us at the Parkinson Performance Center. How do we move neurological rehabilitation from something people access occasionally to something they can truly live through every single day? This conversation will not only be about rehabilitation, it will be about rethinking what rehabilitation and care for Parkinson means, not just recovery after damage, adaptation, neuroplasticity, performance, confidence, and helping people reclaiming ownership over their nervous system. I'm super grateful for you to be here. So let's just start, and welcome once again to my podcast.
Thank you so much for the invitation.
Let's start a little bit with your professional background and just the origins. You trained as a researcher, go back to school to become a hands-on physiotherapist. So what did you see in the research that made you say, I need to be in the room with the patient?
Yeah. It's helpful to provide the context because today, as we know, rehabilitation and exercise is a big part of care for Parkinson's. That wasn't the case back in 2009, 16 years ago. So I started clinical research at Movement Disorders Research and Rehab Center, and we were learning wonderful things, positive impacts of exercise and movement rehabilitation for people with Parkinson's. And we were publishing this work, colleagues, both nationally and internationally, were publishing this work, but I quickly realized when I was speaking to patients or exercise professionals or rehab therapists that it wasn't being translated into the front line of practice. And to me, that was really frustrating because this was a group of folks that were essentially written off after the diagnosis. It's these small conversations at coffee break between, setting up the research equipment is patients really cared and they wanted to do more. And I was looking for that bridge between research and rehab that essentially didn't exist at the time. And so I had to make the decision, well, I can be frustrated about it, or I can perhaps have a small part of changing that. And so that's why I decided to go back to school.
And when you left the hospital, walk me through that decision to really think, okay, what can I be able to do now more and better for your patient that indeed, as you said, like they want to do more that you couldn't do in the actual institution?
Yeah, I mean, I was very lucky at the hospital. I worked at the Parkinson Center of Excellence here in Toronto. I was working with world-class neurologists, neuropsychiatrists, fellows from all over the world training, and I learned so much during that time. But it was at a time in my life where we just welcomed a new baby boy, personally. And, when you speak to our patients and clients, there's a humanity of, not taking life for granted. And I thought to myself, I don't want to sacrifice time with my family, but also I want to do really wonderful work in this way. And so I pivoted and started a practice dedicated to those living with Parkinson's and movement disorders. And one of the things I realized is that I wasn't limited by some of the red tape to try to innovate. So for example, freezing and exercises and rehabilitation was typically done in the home setting or the physical therapy setting or a big hospital setting. And I thought, what if people are living remotely? Should they not have access to sort of the same care? And I thought, well, I don't know. I know there's really wonderful evidence we've put out and others. I said, what if we package it in a way that's more accessible? All you need is an internet connection and a booklet, and maybe you can have some strategies that are just as available as somebody living in Toronto, so 5 hours away from a metropolitan city. And we did that, and I iterated. And something that like that would have taken, I don't know, years to launch in a big institution. And you're able to not only get something out there and get the feedback immediately, but iterate and work with patients to make it better and better, to essentially make it accessible and effectively help patients at the end of the day. And so that was the biggest thing for me. It was like the resource, funding, and some of the red tape that is harder to navigate in a big institution.
Well, I love it because everything that you said basically resonates with many of my decisions for why I decided to also go out of academia and then say, okay, I want to start something that will help them in every day. And it's funny because like I resonated so much with your work, and that's why I'm happy to have you, because I was in a center of excellence as well. And
Yep.
my research was also in freezing of gait. And then there's like this approach of, okay, do more, even, just internet connection. So it's just like, oh, it's so beautiful to have somebody who, has the same approach. So that's really
Yeah.
nice. Um, Talking though about the very, pinpoint of expertise on neurological physiotherapy, help me educate people, our audience here, to actually understand what is the difference between neurological physiotherapy and a normal physiotherapy, like
Sure.
standard one. And so what can also a person, expect, maybe in a different approach, the strategies, the outcomes?
Sure. Yeah, I guess one way to think about it for your audience, a lot of people, if you can go into sort of the medical field as family physician, if you have any sort of general health problems, you might go to a family doctor. If you have diagnosed with a neurological condition or neurological insult, you might be referred then to a neurologist. And then beyond that, if you have something like Parkinson's or other movement disorders, you may see sort of a subspecialist. And I think the same is sort of true on the physical therapy side of things. So folks they're all registered healthcare providers, but neurological physical therapists have focused a lot of their career on understanding the interaction between the nervous system and the body and how that changes due to disorder or disease. And so neurological physical therapists will perhaps do some more training, work with patient populations such as stroke, more commonly spinal cord injury, Parkinson's, and others. And then there's this other subgroup of where we find ourselves in is working with Parkinson's, which are movement disorders, rehab, and exercise professionals that works predominantly with people who have too much or too little movement. And so that's sort of the level of training and interest in that group of folks. To answer your second part of the question, is with that deeper understanding comes, well, what are we exactly looking for? So neurological physical therapists might be able to pinpoint, okay, these are the type of assessments that we need to really dive deeper into, right? So I think about this as, I call it the fingerprint assessment for Parkinson's. So we look at motor symptoms and non-motor symptoms, different domains of movement, like aerobic capacity, strength. We look at things like motivation because we know apathy can be really affected in Parkinson's disease. And so having a deeper understanding of the disease then informs a more precise or focused rehab approach that then informs the treatment.
Yeah. And how did you, decide even just to think, okay, I want to become a neurological physiotherapy? Because, I have from my side this big obsession and passion for movement, and I
Yeah.
started as a former pro ballerina. But yeah, what was your spark?
Honestly, it was the people, Gaia. It's the conversations. Like, people, and especially at the time, we were seeing more folks with Parkinson's who are coming in for research who are older. So they've lived this beautiful life. And they provided so much wisdom to me. And it's these interactions that I felt like we can do more for these folks. And I love motor control. I love sort of the brain, the interactions, but I think it was like the human element of people willing to put in the work and try to do a little bit more than the standard of care. And I felt, I was like, I want to work with these folks. Like, I want to be happy in my work ultimately, right? There's a humanity in that. And yeah, I wanted to do something that would sort of bring me joy every day and learn interesting facts about people's lives as a human, not only as a person, sort of as a label of Parkinson's. So,
Well, we need more people like this. So it's beautiful to hear. Um, Passing though on the specific research, a lot of your work was indeed on freezing of gait. So can you tell us a little bit more also what is happening in the brain in the moment, in the instant of an actual freezing, and why just the idea of, try harder, it's not working?
yeah, it's a great question. And our understanding is evolving of freezing. We still are trying to figure out exactly sort of the mechanisms around freezing. Essentially, sort of at a high level, if you think about, well, if we walk and the evolution of moving or walking in general for people who don't have Parkinson's or don't have a neurological insult or disease, is essentially the brain movement pattern is fairly automatic with some level of support at higher levels of the brain. So, for example, if we go into a new environment, there are different areas like the somatosensory areas or the cognitive areas or the limbic systems that sort of feed in to navigate these newer environments. But it's fairly sort of tightly controlled in these locomotor regions of the brain, not to get too sort of sciencey. But in Parkinson's, our understanding is that that automaticity is driven by sort of the basal ganglia, dopamine that's produced by the brain. And what we see is when there is less of this neurotransmitter of dopamine that we see often in Parkinson's, that automaticity gets sort of lost. And Bas Bloom, who I'm sure you know, has said this wonderful statement that the brain has a wonderful a capacity to change, shift, and compensate. And so what happens is these higher level regions of the brain start sort of picking up um, the where that automaticity falls short. And our understanding is that when people enter into certain situations, there is an interference between how much capacity the brain is able to handle in that moment and all those compensations that are happening of the brain to pull on those resources. And so when people find themselves, for example, walking and then holding on to some groceries while taking a turn, there's a lot of interference that happens. And there's essentially a breakdown of the walking that happens. And we think that is connected to why we see these freezing episodes, particularly in these instances where that interference happens.
Yeah. Anchoring on the point of the compensation mechanism happening in the brain, in science we developed and we understood actually how to be able, to help people with something that we call cueing compensation strategies. So help me also here just educate our people in understanding what are these, how can we actually, implement them in a specific case. There are different types, so some, might not be working for others in the same way. And from there, tell me more about your specific research that you did in cueing compensation strategies.
Sure. And yeah, just building on off what we've just talked about, we can also leverage those other parts of the brain to help with movement. And how I explain it really simply to my clients and my patients, it's like imagine that you're on a big highway and that highway is blocked. But that highway is where the brain sort of sends those signals to the body to sort of move and navigate and walk through these different environments. But if there's a car crash on that highway or it's blocked and that signal is not getting through, what we can do is take a sort of a side road, right? And that side road may be going to the visual system of the brain, so putting lines on the floor to bypass that sort of deficient basal ganglia that allows that target for that brain to step to. Other type of cueing are auditory cues, so using parts of the brain that with around that process sort of auditory centers of the brain that process music or sounds, for example. And that's sort of another bypass or a different road that the brain can take to initiate those movements. We then look at movement cues where we change the biomechanics of the posture to be able to put a person in a better position to take a step. Other cueing strategies include action observation, so having the brain sort of match a movement that it sees. And these are all ways to bypass that type of, that blocked highway that we think about when it comes to sort of sending the brain to signals to the body and for walking and freezing in particular. For us, what we did in the lab is looking at visual cue strategies. And again, the theme is having these conversations with patients. And I remember a spouse of a patient said, "Haseel, I can't walk around with tapes in my bag, and I can't put them down in grocery stores. Like people will look at me very funny." And so I thought, well, could we train this as a protocol, a gait training program? And so we essentially put that on a treadmill to see if we can train the brain to walk more effectively with these cue strategies. And what we found in both groups compared to the control Parkinson's group is people were taking larger steps, they were freezing less, and they were walking with sort of a greater speed and more confidence.
Is there any cue conversation strategy that you, let's say, found it's very original or funny or like really just crazy weird? Because I myself have, and some of them are really funny.
Have I found some interesting ones, are you asking? Yes.
Yeah.
I remember a gentleman coming in and he was in a wheelchair and he had quite significant freezing, but he had knee pads. And I asked him, do you play volleyball? Like, what is this? And essentially what he would do, a gentleman who could have a hard time walking, all of a sudden he went into like a kneeling position, like a runner. And he would lunge and jump into sort of almost a sprint to get out of the freeze. That to me was one of the most interesting, fascinating things. And you couldn't even tell after he did that he had freezing until sort of he turned around. Another one I've seen before, and that's in the literature, is somebody doing a full jump to take the turn, to bypass the turn, which again can be very scary because if somebody sees that and says, "Oh, let me try that," and doesn't have the balance control, that can be quite scary. But you'll be, as you know, you'll be very surprised to ask patients, "Well, what do you do?" And I always lead with, "Is there anything that you've come up with that helps you get out of these freezes?" And you'll be amazed. Have the video recording because it's important to sort of share some of the strategies that could help others.
Yeah. Yeah, absolutely. I agree. And indeed, I'm also happy that you shared this because for me, it's so fascinating what the brain, can do in terms of compensation and trying to bypass and finding, such original compensation to overcome the freezing. But I like how you also frame it in this last point. Well, what do you, do what you have found? So is there a way that you in your work try to encourage people to actively try to look for a strategy that helped them?
Sure. Yeah. I think there is a little bit of a disconnect because we're doing this unlocking movement program for particularly people across Canada looking at freezing. And one of the first questions we ask them is, what do you know about freezing and what did the doctor or neurologist tell you? And some people say nothing, which is a majority, unfortunately. Others are like, oh, go listen to music or go put lines on the floor. And it's left to them to sort of explore. They actually get a lot of information from fellow people living with Parkinson's. They get for any strategies that are effective for them. But I do think there's this disconnect between what cueing actually is, what their freezing looks like, and it's only later on that I find, after experiencing freezing for a few years, that they do actually start exploring because it's not flagged immediately, which I think it should be, of course, to get out in front of it.
Your research, though, it's also more recently even more focused on the integrated model of like a really functional care. So we talk about mind, brain, and body all together. So what does, treating all three at once look like in practice for you, and why does it matter so much?
Yeah, I give a lot of credit to Dr. Lidstone, Dr. McGilvery in Toronto, who've come up with this model in functional neurological disorder. And they brought me on as the physical therapist. And typically, we would see, as a neuropsychiatrist and neurologist and physical therapist, we would see the patient individually. And we would see the challenges through our own lens, actually. And unfortunately, so patients came out with a lot of that you have to work on this and you have to work on this, and it can be quite overwhelming. Now, this new model was having all three of us in the same room, and we centered the person living with Parkinson's and what was most important to them, and using our clinical skill set to be able to best address the challenges that are most important. There's a wonderful figure, I think out of the Netherlands, that asked clinicians, what do you think your priorities are for your patients? And they compared that to asking the patients themselves, and they were on completely different pages here. And that just speaks to what we think is most important may not be as important for the patients. And so having that open conversation and dialogue to say, what do you find the most challenging? And if we can address that right now, that can be a really good foundation to build out a rehab program that you will actually stick to.
Yeah. This is a big gap, I agree. And I would like to ask you if you realistically and genuinely see also other gaps, let's say between the fundamental research and the clinical practice, but then how can we actually, help people indeed in daily life?
Sure. I think there's a lot of gaps here. One of the things is access to care right now, and I don't know how it is over there, but here, once you get diagnosed, to see a movement disorders neurologist may take up to a year, 2 years even, and that is a foundational time period in which people can get care and change the trajectory of the disease. The other thing is that funding is limited, and so accessing public funding for somebody living with Parkinson's is harder than, for example, if you had a stroke or a brain injury. There's a little bit more support around that, and then the area of expertise for working with people who truly understand Parkinson's, and so I think there's multiple gaps, I think, that need to be addressed from a systems level. But this is why these conversations matter. I think personally, I'm of the belief in 2026, if I have a knee injury, I want to look for the best person who can deal with my knee, not the one who's just closest to my house ultimately. And so we need to leverage our technology and expertise that is now accessible not only across the province, but across the country and perhaps even internationally.
Yeah. I'm grateful on how you frame it, because one thing that I see all the time is that there are indeed big gaps also in the different expertises, and we need many different profiles for a good team around the person with Parkinson's, of course, also other neurological conditions. But what I unfortunately sometimes see is that maybe as a society or even from a cultural level, we are so biased and we think, the person with the white coat will give all the answers. But unfortunately, sometimes the practice, comes from people like you, practitioners, physiotherapists, coaches. So I would like this conversation to really open the eyes also for our patient and our listeners to really ask and constantly, check, okay, who are all the people that needs to be in a team? And so here for you, the question, what do you think would be the best, let's say, arrangement of people in a care team for Parkinson's?
Yeah, I personally think there needs to be almost a buffet of people. So you have an exercise professional, you have allied health, speech, physio, OT, neurologist, Parkinson's nurse. I mean, I think the list kind of can go on. And I talked to a client one time and says, I want it to be like an accordion. So I can expand my care team or I can contract it depending on where I am. But the main thing is I want it to be accessible, and the people a part of that care team have to understand, truly understand what I'm dealing with. And I think targeting both disease education, mental health, physical health, and of course there's a line that sort of intersects across all those things, should be sort of the pillars of care, in my opinion, personally, for anybody living with Parkinson's. But I agree, it should be a buffet, and for anybody who wants to go back for seconds at their stage in their life and what they need at that point should be able to access that. I know that's not answering directly, but I think more so from a high level principle.
It makes, yeah.
Right.
And so for a person that, for example, just get diagnosed and they're really, really new in PD, they don't know maybe fully what to expect. They might just be, hearing these stories about the worst case scenario, and they don't even think, oh, maybe it's possible to actually live well with Parkinson when you have all set in place and a good care team. So what would be your first advice to this type of people?
Sure. My first piece of advice is recognizing that you can live well. So I think even in your sentence, your questioning there is a perception of what it's going to be. And as we know, no two people living with Parkinson's are the same, right? They do not present the exact same. The symptoms may look very similar, and it's like a fingerprint, but everything that sort of comes together is uniquely ours, right? And I explain that to clients and patients. Fundamentally, there's been a big shift, is that exercise is no longer an adjunct therapy. It's a core component of managing their Parkinson's. I think over the last 5 years, there has been finally addressing the unmet need of mental health support in Parkinson's. Evidence-based disease education should be important. For me, and I think the work that we do can be really powerful for patients that can take control of a situation that they feel out of control. Right? So Parkinson's can feel up and down, and there's very little control, but that piece of agency, in my opinion, is a key component of living well with Parkinson's. And that agency comes to understanding what this is, what you can do today to help your future self, right? So taking care of your health, taking care of your social health, physical health, your mental health. And I think these are the things that we need to hit, not only from the point of disease, but from the wider, from a society standpoint, for all neurological conditions, in my opinion. But particularly for folks living with Parkinson's, because it can make a huge impact in their life.
Yeah. When it comes to the actual expectation, and outcomes for rehabilitation, how can we help people to understand what to really look for, so to have those good outcomes and expectation? Because, very, very genuinely, and I want this conversation to be fully open. Like, I had people who came to me and says, my physiotherapist is treating me as if I'm a child, and it's just an easy massage, maybe 10 minutes on a treadmill, and I'm already out of the studio. And I get so sad and frustrated at the same time. And I know this is not the type of work that you do. So how can we make sure that people really, just understand the difference between what is good care and what is not?
Right. And I mean, there's now some really wonderful guidelines that we can point to. So one of the things I try to empower clients as much as possible. And I say to them, you get to choose where you put your time, energy, and resources. So I often ask them, interview your healthcare team, ask them ask questions. Why are we doing this treadmill? Why are we stretching? And the healthcare provider on the other side should be able to answer that question effectively for what you are going through. And for us, Sarah Gari has a wonderful picture and image of how many hours we spend with any healthcare provider, exercise professional, and it's quite limited for how much they have to spend in self-care and self-management of this disease. And so if we don't empower and educate people of this is what you need to be doing to help your Parkinson's, and this is what the evidence says can and how it's going to help, then to me, that if you can't answer that question, that is suboptimal care for our clients, right? And so when people are doing sort of treadmill training, or they're doing balance training, both reactive and anticipatory balance training, or we do all these sort of freezing strategies, they should have a good understanding of why they're doing what they're doing and how that actually applies once they leave this clinic, because that's the most important thing. The impact lives beyond these four walls. And I think if you lead with those questions, and your therapist or whoever your working coach, exercise professional is able to answer those questions in a way to show you, and they're very transparent of what that is, I think that will give you a good gauge for your audience if you're in the right place.
I would like to go also to another field of expertise of yours, which is functional neurological disorder. So can you tell me more about this?
Yeah, functional neurological disorder is another group of patients we see in the movement disorders clinic. And we think about disorders of movement due to a structural damage of the brain. And what we're seeing in FMD is that there are a flip side to that coin, is that there can be influence on movement due to software issues of the brain, is how the brain sort of abnormally communicates with each other. And so what we see is there's patients come in with this condition of FND, where there's an issue with the software of how the brain and the body communicate, and that results in too little movement or too much movement, as well as sort of other neurological symptoms. But rehabilitation and movement retraining can be a really effective tool to retrain those brain patterns. And I think it's actually a wonderful model of how we probably should be supporting all people living with movement disorders, Parkinson's, ataxia, PSVE, MSA, and the list goes on, because it pulls from support from both psychology, neurology, and rehabilitation as a triad.
Is there, in both FND but also Parkinson, a specific symptom that you have found maybe it's more difficult to treat or just more resistant even to potentially neurological physiotherapy? Or is it just, well, it depends on the severity, depends on how many years of a diagnosis a person is already in?
It is a tough one. I think there are challenges in both groups, of course, and of course, disease duration, presentation. For example, dystonia is a challenging one. So, for example, if somebody has dystonic posturing in both Parkinson's and FND, a functional dystonia or non-functional dystonia, wrote a paper on FND dystonia, what we often see is if a limb is, and for those who don't know, like dystonia is this either fixed or repetitive sort of posturing of either the limb. Oftentimes we see it in the neck or the foot or the hand. But over time, if that is maintained, we see structural changes ultimately, right? This is where we see contractures, and we can see sort of these fixed, what was once non-fixed dystonia become fixed dystonia, and the brain sort of maladapts to that posturing. And that can be really difficult to treat. And it continues to be a very complex and challenging symptom overall. And sometimes does require sort of advanced therapies. But I do think we need to be able to target the importance of targeting this early, because we know things like stress and anxiety actually ramp up dystonia. Physical rehabilitation can actually help. Exercise can help. So all these things need to be sort of integrated quite early, rather than immediately going to, let's go into Botox right away, and then perhaps surgery and so on and so forth. But that can be a challenging symptom. That being said, if we're able to target this early enough, we can see quite significant and improvement, and patients can continue to have a really good quality of life. Yeah.
I know that you do care a lot also of families, spouses, and partners of patients. How do you look at them? And how do you think that your work can impact
Mm.
people that live around patients?
Yeah, I've been incredibly grateful from working side by side for a neuropsychiatrist for 6 years. And one of the most powerful things she said and did in the clinic, she turned from the person who we were supposed to see with Parkinson's and turned to the spouse or the children and said, "How are you doing?" Full stop. And the responses you will get, they feel validated, can become really emotional. And it's the first time sometimes people have asked them that in a hospital or rehab or medical setting. And I think it's such an important place to start, because they'll share, right? And I think, again, these conversations lead to potential ways that we can better support the family system when it comes to Parkinson's.
You know, it is very true what you also say that sometimes they have never been asked it. Like even in my program, we have actually
Yeah,
coaching for even spouses and families. So
great.
sometimes I remember a few, in this case, it was a few wives that they were very emotional and telling me, grateful for these calls because nobody in the clinical system ever asked them what is, happening, how they're doing. So I just tune also so much with your approach and your sensitivity. So yeah, thank you for this. And I know that you also wrote a book though,
Yeah.
but at that point was for NND and how to explain FND to children, if I'm correct, right?
Yes. So here I don't know how it is over there, but the system sort of categorizes you into either pediatrics or young adults. And then as soon as you turn 18, there's this weird thing where it's like, oh, you don't sort of fit into the adult patient population. And what we were seeing in FND is a lot of young people were getting this diagnosis, um, and not getting the support they necessarily needed, and the wait lists at the institutions were quite long, and there was a lot of misinformation out there as well. And I thought to myself, well, how can it came really off the back of these conversations of like, I just need to be able to share something that feels a little bit more empowering to family members, and then younger people living with FND or being diagnosed with FND. And I thought, okay, well, why don't I just, inspired by a case of a young woman, a teenager who came into my clinic and she had this dragging foot, this weakness. And she actually did dance and she had a background in dance. And we leveraged that to tap into these automatic movement patterns. And it was the first time in thinking years she was able to step without that limp and that dragging of that foot. And I look back at that story and I thought, why don't I just sort of share this in a way that feels accessible? So inspired by her, I put it together, and the response, and just, you can easily download it on the website, but it was a way for parents to understand what rehab looked like for FND because it looks different. Number two, it gives younger people a sense of what they're entering into, because there's a lot of anxiety entering into the clinic of like, what's happening in my body. And then three is to provide a little bit more education across society, and sort of remove some of that stigma around FND, and recognizing that this can improve in young folks.
I will be putting all these also links and how people can find your website and the books under the episode. So that's going to be nice for everybody. And now I would like to do a little bit of they call it game.
Okay.
So I'm going to do a patient, okay, like a case study. Of course, all is fictitious. I'm like literally inventing it up now. And let's just think, from your perspective, what would be your first approach? So let's say that this is a woman with Parkinson in her 60s. She freezes, especially in the doorways. She had balance issues, so she has been falling in the last year quite often, at least once a month. She developed a dystonic curling also in one of the foot, which is affecting her walking. And now she's even scared to leave the house, to go out. So her confidence is completely off. How would you approach this case?
Yeah, so one of the things I tend to teach other healthcare providers is I use this thinking about the treatment before. Of course, we'll do a clinical assessment, and I talked about the fingerprint assessment to get a really deep history of, what does the freezing look like? When does this balance? Is the balance and the freezing connected? Where does this fear of falling come from? Was it after the falls, or is there a long-standing history of perhaps a higher anxiety profile? All these things we want to dive into. But if we want to get into the sort of the meat of what the treatment is, I use an approach called the OSM, and it's the optimize, strategize, mobilize. And most people who I talk to, as you were describing before, will get people on the treadmill right away. You might get that person right on the treadmill, let's work, work, work. And then you're not seeing the benefits because that's what they read in the paper. But what you want to do is really optimize the Parkinson's, have a good sense of when are people taking that medication. And what we know is dystonic curling can happen when people are coming off or sort of just coming on. And so perhaps optimizing and recognizing when are we seeing these patients, where are they, making sure we're targeting some of the fear of falling, where is that coming from? Exploring kinesiophobia, right? The fear of movement, right? These are all things that need to be optimized from a Parkinson's standpoint before I then go into level 2 of strategizing. So strategizing for this particular patient may look at doorways, and I might not lead with a cue. In fact, I might give them something and looking at their profile of how they freeze. Do they sort of get stuck right at the doorway? Do they festinate on the spot? So building the profile of the freezing phenotype can be helpful. And it may be just as simple as, okay, in the interim, to build up that confidence, instead of looking down or looking at the doorway, and this is some of the research that we did, is when people walk in through the doorway, we look at where their eyes were looking, and it was always at the perimeter. And we thought, well, what if we give something a target, that automaticity we talked about, and we put a target beyond the doorway, and all of a sudden they're able to get through. It's like, oh, maybe I'll just start with that before I go into any exercises, right? And then we can start building out a exercise program that targets some of the freezing, start exploring the kinesiophobia, start leaning into movement patterns that feel scarier. For example, getting up and down off the floor, for example, right? How do we approach a door with different levels? So what I might do is big open doorway, we'll get through. And then I'll shorten the doorway. And then I might get them through a swinging doorway. We've got some beautiful elevators here. That's scary. That might be the next level. So there's not all doorways are the same, right? As we know. And so it's thinking about optimize the Parkinson's, strategize for the movements, and build those skill sets of the foundation. And then from there, we might start targeting these sort of mobilizing, getting them into this exercise routine. And so that's how I would approach this person.
Well, I hope that, all people, no matter they might not have the same symptoms, of course, but they're just taking notes in the approach. So even to ask the question to mimic your approach to their basically, care team. So that would be nice. But tell me more now about Neurology Rehab.
Yeah, Neurology Rehab, what was it? This crossroads, I think a new chapter in my life. And as I left the hospital and I was hanging out with my son, at the time he was like 1 year old, I thought to myself, what do I want this next chapter to look like? And ultimately, I didn't want to lean back into just, serving all patients. And I said, I deeply care about those living with Parkinson's and movement disorders. So I said, why not just, you're literally seeing my new space. It's opening 2 weeks from now. So you get a sneak peek, which is great. And this was all carpet. And I thought, let's go on an adventure. And I wanted to create a dedicated hybrid clinic offering both telehealth and in-person care for people living with Parkinson's, FND, ataxia, and other movement disorders. And Neurology Rehab is built on basically one principle, improving access to specialized care for those living with movement disorders, built on 3 principles of self-management, education, and specialized care.
That's beautiful. And you're not, though, indeed treating only patient, you're actually also certifying and teaching. So you're helping other professionals to reach a level of understanding and just, basically create a toolkit that will be then more, let's say, beneficial for people with PhD. So how do you approach the idea of also, lecturing, and what is your mission in helping other clinicians to become even better?
Well, I think back to 16 years ago, I was frustrated with the fact that I couldn't see this clinical practice being implemented where it needed to be. And so I thought knowledge is meant to be shared, right? It's almost like passing out a candle. All of us can sort of learn from each other. And I've had the incredible privilege of not only training in Europe, but the US and Canada. And the people who I looked up to the most have been people who shared their knowledge and were able to, bring me in and said, this is what I do and this is how you might be able to. And I have these wonderful mentors from around the world. And I thought to myself, well, if I've spent a lot of time doing this, perhaps other people could benefit from the same thing. And so, I'm just sort of building off on the advice and how I want to be able to help the Parkinson's community is by multiplying the knowledge as opposed to just sort of having this in these 4 walls, because that's not the mission of this thing.
So what is the mission? You are such an incredible researcher and clinician and professional, but also an amazing soul and person. And it just, comes through so obviously. So what would you like to achieve, both, let's say, just as Haseel, but also for Neurology Rehab?
I want to try to build a model that feels supportive of the movement disorders community, where they can turn to and perhaps an example of what care could look like. Everything I've done in my career, even entering into the Parkinson's world 16 years ago, Gaia, people looked at me like, there's no research, there's no evidence behind this. What are you doing? What type of job are you going to get at the end of this? So I've always, in my career, I've always appreciated trying to build the evidence, prove the model, and then get the thing out there, and provide an impact, a positive impact of the lives of people living with Parkinson's and other movement disorders. And so the goal is to just leave this place a little bit more positive. And if I can positively impact people I've worked with, then I think I've done sort of my job. I know it's not a professional, clean answer, but that's what it is, honestly.
I think it's so genuine and authentic. And I see it's not just, so sometimes I have this idea that many people think of a mission just as a future goal, but you're actually already doing it. So
thank you. It's very scary. It's almost like you've got to put your own sort of ego aside, and like putting yourself out there is hard for most people, and it's incredibly hard for me. Like even entering into the social media world has been like, I don't want to do that. You can look back at all my posts of like, I don't want to show my face, but what I've realized is people need to trust other people if they're going to work with them. And I think there's a lot more that can be offered. And when I look at the standard of care, I think we're not serving people the way that we can and care for them. And I think that's where your mission, my mission, others in the community have really started pushing the boundary to say, there's more available to you. And so if I have a little part of that in this wonderful community that we're all part of, then I'm really happy.
If a person would like to reach to you, let's say they are around the area in Toronto or in Canada or even abroad, how do they call you?
Yeah, they can just reach out on the website, neurologyrehab.com. There's some programming that is going to be available, like some of the self-management programs. If they're looking for physical therapy, then of course we can offer some telehealth and in-person care at the clinic. And if not, if I don't have anything for you, I'll sort of recommend people that I know in the community as well, right? So they can reach out www.neurologyrehab.com, and there's a little contact page, and we'll hopefully have some more programs that are popping up perhaps in the future. But yeah, they can just reach out, and then they can check out the Instagram page if that's helpful as well.
So we're about to conclude, but I would like to ask you also a few very last questions. And one of these is just very, if you want, even philosophical or existential. So when you think of life and the brain after working with major conditions like Parkinson, like FND and others, how do you think of the brain and life today?
It's a good question. I think I had read somewhere that all the worries that you have in the world, when one of those things gets compromised, the brain and life, you have one worry and one focus, right? So before it's like, oh, I'm not going to get that job, or I'm not going to be able to do this or go on that vacation. And what I've learned from people living with Parkinson's is they become deeply focused on what matters. And when they share that, I close my mouth and I listen. And that for me has been sort of the biggest shift in this last year, to go out into the abyss of unknown and saying, this is how I want to live my life. I want to be close to my family. I want to spend time with the ones I love, friends, family, loved ones. And so I think this has taught me a lot around what it means to be human. I give all credit to the people I've worked with, because I truly think that they've taught me more than I've taught them.
Very, very last. If there's one thing that you would like to completely change or redefine in Parkinson, what would this be?
Great question. Can I ask you first what your answer would be?
There are many things. I don't have just one thing.
What comes to mind for you, Gaia? I'd be curious.
I would say, even starting generally from the medical degree, the idea of having way more this holistic approach, because what I see is that now, like, I was very lucky myself to have one of the best mentors probably in the world of Parkinson, and many knows the name of Haseel, and he is the one who constantly talk about this holistic approach. But there's so many other doctors that do not. And so I see really, people that are frustrated. And so thinking of, as we also talked before, you as a doctor, reach out to a coach, reach out to a trainer, reach out to a physiotherapist, reach out to a nutritionist, reach out to a psychologist or a mental coach. Instead, it's just there, admin work, see you in 6 months, more pills. Now, of course, it's also the system that it's broken. And so genuine good people cannot do the doctor works because they have just to fill in, the admin work. So that would be definitely one big thing. But on the other side would be really try to reach out more to people and educate them, which we are indeed trying to do with my company, to really think, look, this is just one piece of the puzzle. It's on you to actually, create your team and try to take the ownership on your life, because sometimes I really think we are biased as a society that we have something, there's a pain, disease, something happened, and we go to the hospital. But the hospital, by default, it's a sick care system. They think in terms of symptoms, disease, and avoid the worst case scenario. And we here for people, we need to change the script and think in terms of healthcare, performance, longevity, quality of life, and living well. So it's a completely different paradigm. And I like your work because you are stubborn enough and ambitious enough that you can do it. And you are showing also a different model that it's possible.
Yeah, I think I love that, and I think where people fall short, or the society or a system falls short, is we don't give enough people enough credit who are living with Parkinson's. Set Give people the tools that they deserve to succeed and live well with this disease, and that's what I think would be the biggest thing that needs to be shifted, is give people the tools and the access that they need to live well with Parkinson's, because they can, and the evidence is now showing it. And so what that, as you've described, all those resources, exercise professionals, rehab professionals, but let them be able to access that. And if they can, I agree with you, there is a very reactive model. And if we can build people, and it's almost like insurance, like we pay for insurance all the time. Well, we don't say, well, what's this? Why am I still paying for insurance? Well, we pay insurance for our future self, right? And I think we need to start thinking about Parkinson's care in that way, to say, you doing these things now will help you long term. You might not see an immediate benefit right away, but it's going, like, if I can track somebody who gets that access, who exercises, who does all these things that we've talked about today, versus ones who doesn't do any of those things or doesn't have access, they're markedly different, 5 to 10 years from now. And so, yes, give people the tools and access to help themselves live well with Parkinson's. That's my sentence.
That's nice. Very, very last. And this is like a tricky one. Is there something that you think it's clinically correct, but that it's widely misunderstood? And the mirroring question of this is at the opposite. Is there something that it's widely believed, but it is actually not correct in part?
Okay. Yes. I would say the term Parkinson's disease.
I loved it.
Disease suggests a linear trajectory of a condition that everyone is the same. We probably should be calling it, and it's widely accepted that this is Parkinson's disease. It's probably should be called Parkinson's syndrome. And that's to answer your first question. Now let me think about your second question. Can you repeat it again? Okay.
Yeah, at the opposite. So something that it's believed, but it's like, let's say, not correct. Which I see could be also, actually, for your answer, could be both.
Yeah.
But
let me think about this. Sorry, you put me on the spot here. I was doing so well until then.
yeah, no, it's still great. I mean, maybe in terms of let's say the actual progression, like everybody think indeed it's just going to be like
Yes.
anchoring actually on your first part, that everybody think it's just going to be worse and negative. It's like, it's not correct. Can be better.
Yes, exactly. Yeah, that's a great one. So yeah, I'll piggyback on your point. The idea that in the public eye that things cannot improve in Parkinson's. Even this week alone, I saw a gentleman who I've been working with for the last year, and the markers of improvement or outcomes that were positive have been, not only has he lost weight, he feels stronger, he is more confident at work, and initially wanted to retire early in 6 months and is now thinking, I'm going to go for another year. Like, these are all markers of improvement, and he's on the same level of medication. So if we take that whole clinical picture together, I think that's an improvement on all fronts, really, right? And so, yes, I will piggyback on your point and agree wholeheartedly that things can improve with Parkinson's, even though in the face of a neurodegenerative condition.
Of course. Any very last message that you would like to leave for our audience?
I think these conversations are important, and thank you for providing an opportunity to have such an important discussion. I can clearly see how dedicated and passionate you are about this work as well, and thank you for putting yourself out there to bring this community together, because I think it's an important conversation to be able to push that boundary and continue to advocate for yourself, and because you deserve more for your audience, and things can improve.
Thank you so much for
Thanks, Gaia.
all the wisdom, all the tips and tricks, and for being who you are and how you are. Because I
Thank
think
you.
I'm really, also, I feel your passion back and I see your energy. So it's just beautiful. Like sometimes it's hard. And
Yeah.
so I know that like sometimes it's good to hear that, okay, other people like this exist. I'm not the only weirdo here, so I love it. But so thank you so
Exactly.
much. And
Thank
for
you.
our listeners, I will be putting all the information and links under the episode so they can also reach to you. Thank you.
Thank you.